Everyone. My name is Jonathan Woolfson. I'm based in Atlanta, and they asked me to talk about why we bought so many iTraces. We've got 12 locations based out of Atlanta. We're in three different states. Started primarily as a LASIK practice, as a referral LASIK practice, and then we now have 10 cataract surgeons, 20 surgeons in total, and 26 doctors. And so for us, one of the big issues is to make sure that we standardize our decision making. But that holds true even if you've just got a single practice, because I think you got to make sure that you're making the same decisions from one patient to the next, and that you've kind of thought that out beforehand. And so for us, is this thing working, or did we decide to?
It is.
Which one is it?
Like 3 o'clock, right there?
Okay, no financial conflicts here. I decided to put up like what our basic decision making is, because we've really gone away from talking about bringing patients in for a LASIK consult per se, because it's really become refractive surgery consults, like we all know, right? That interface between doing lens surgery and LASIK surgery is not so easy to define as it was just a few years ago. So now we've got all these different options of doing early cataract surgery, ICLs, or LASIK. And so for us, especially when you're talking about hyperopes, and we'll still do LASIK on hyperopes, we'll still do LASIK on high hyperopes. But obviously, IOLs make a lot more sense for most of those patients. And so if patients are over age 50, we're really guiding them towards IOLs. If they're +3 or less, then LASIK's still an option if everything else looks good and there's no evidence of cataracts. If they're pre-presbyopes or higher, then we generally do not give them the option of LASIK at this time. And this all kind of ties into the trace here, because this helps us make the decision making easier, but also helps to demonstrate to the patients if they've got any kind of lens abnormalities on the dysfunctional lens. So I just did a show of hands here. First of all, who here does LASIK? Okay, so we've got a fair, not that many. Wow, okay. So the folks that are doing LASIK, is anyone using this risk score analysis? This was put out by Randleman and Stulting about 15 years ago or so to help standardize. Is anyone using that? Yeah, you are, a few of you. If you're not using that, are you using anything else that is a standardized point scale or standardized risk analysis system? No, okay. So I put this up here because this ties in directly to Tracy on the top line. And the way, for those of you who haven't seen it, or if you saw it a while back, you can see it originally came out in ophthalmology in 2007. And what it does, it allows you to kind of take every patient and standardize the decision making. And so you've got those 5 different parameters there. Do I have a pointer on this? Yes. Yeah, okay, there we go. 5 different parameters: the topo, residual stromal bed, age, and the pre-op spherical equivalent, along with an initial pack. And what's interesting here, and I think we all kind of know this, is that if patients are younger, they get 3 points. Okay, so you've got 5 different parameters. Each parameter rolls up to how many points for each one of those, and then you add them up. And if you get 4 points total, we don't do LASIK. There are some exceptions, but very, very, very few. And so patients are 18 to 21, they really get 3 points. So everything else has got to be perfect. If their prescription is higher, we're not going to do LASIK. If they're a little bit thin, we don't do LASIK. Residual bed depth below 300, we won't do LASIK. You'll notice on this, and so what happened was, for those of you who don't know, Dr. Stulting used to be at Emory, and he left Emory a while back and came to work for us about 13, 14 years ago. And he was the one with, Randleman was his fellow at the time. They pieced this together. When he came on board, we weren't using it, and we decided to go back and look at 200 cases that we had done previously to see, okay, does this make sense? How would it have changed our decision making? And there were only 3 patients that it would have changed, and there were marginal decisions anyway. So we decided to adopt this. But what it does do, it allows us to make sure we're making the same decisions from patient to patient, but also with multiple centers, I can have the optometrists do our initial evaluations. And everything on here is objective except for the topo, right? And so you're looking at topography patterns that are asymmetric bow ties, inferior steep, or just flat out abnormal. All right. And abnormal doesn't have to be formed for keratoconus. It could be just the shape just looks abnormal, and we're just not going to do LASIK on that. The point of all this is that the topo is the one thing in our LASIK decision making that has got a fair amount of objectivity to it. And in the past, we would just do something like this. We'd get a topography and take those 5 points and figure out an IS value and think we were doing pretty well with it. But it's so much better and cleaner for us to have this done automatically. You can do this on the Penacam, and we do this with a Penacam. But we've found that the Tracy has given us a much more, what I think is a real value for that is something that we can use. And so obviously down here you've got the number, and if it's less than 0.5, you consider that normal. If it is between 0.5 and 1, then it becomes an ABT, an asymmetric bow tie, and then anything from 1 to 1.4 ends up being inferior steep. So this has really allowed us to standardize that decision making a lot. And so when you go from center to center, that's really become something that's really important for us. I think if you're not doing that, you need to have something that's objective. Even if you've got, if you've got 1 or 2 practices and you have someone else in the clinic helping you screen the patients, or even if you're just doing it yourself, I think it's super important, especially with the med-mal issues. You need to have something that you can defend that you thought about beforehand. Since we've been using this now for 13 years, it's a little bit more conservative than some folks like it to be. We found that we're really not turning patients down in any numbers that we wouldn't otherwise. And in the last 12 years that I've been using this now, which covers about 50 to 60,000 LASIK eyes, we haven't had a single ectasia patient, at least not one that I know of. And we would probably know about it. So it's kept us out of trouble, and it's given me that kind of confidence that we can follow this pretty routine, very easy to teach, very easy to follow routine on the LASIK side. So for me, on the LASIK side, that's made a lot of sense. Our cataract surgeons really, really love the Tracy as well, for different reasons. And so we've got several cases. I know we're running a little bit behind in general, so I think we'll just go through 1 or 2 of them, and then we'll be done, and we'll take questions. We've got a 60-year-old patient, prior LASIK, and now with coming in with cataracts, symmetrical topos. I think everyone knows about the different lens options. If we used LALs, it would mean we don't want to do PRK on top of that. And so with our patients, what we think about when we're doing LASIK is that if we've done LASIK, we don't like to do PRK. We don't like to lift the flaps if they're more than 2 years out. We can lift them, and in years past, we lifted patients that were 15 years out. And lifting the flap and doing the enhancement and getting the flap back down is not the problem at all. It's the fact that you're going to get a much higher risk of ingrowth afterwards. And so, if you're going to have these LASIK patients that come back, and whether you're going to do anything else on top of them afterwards when they come back for cataract surgery, your options afterwards in our clinic anyway are limited to PRK. So it's really important for us to kind of nail that initial cataract surgery, all right? And it's easy for us to take them to the laser, but these low myope PRKs are unpredictable. And so the reason I bring this up is that there's a lot of patients running out there who have had LASIK, now coming in for cataract surgery, and the stakes are higher now to make sure that you nail the prescription first time. Because lifting up that flap or making another flap are not terrible options, but are options we want to avoid. Doing PRK is not a great option, especially if you end up with a low myope, because you can have some unpredictable results with that. And so you really want to nail it first time, okay? So in general, we just want to kind of get them right the first time. I put this up here as well. It's a 25-year-old, -11, PAX of 505. Who here would think about doing LASIK on a patient like that? No one, right? So what's interesting is when you look at this on the, I'm going to breeze through this because we are running behind. When you look at this on our risk analysis score, it just lights up there. Right? So you've got 8 points there. And remember what we said, anything that's 4 or more, we don't do LASIK. So here's a case that I kind of wanted to go through. That's a patient that came in their 50s with multiple things going on, glaucoma, AMD, retinal tear with a laser, status post-LASIK, had a minimal prescription. And if you look at the bottom, only a minimal amount of cataract formation. Look at back of the eye was showing some significant pathology. And we're able to look at the Tracy and say, okay, wow, we've got a 10 on that scale. The Tracy is not really, is showing us the cataract itself is not a significant problem. If you're down here, the spherical aberrations are 0.9. And for us, looking at the pupil size has really helped us a lot. If you look in the top left there, it's going to show the pupil size. And if you're looking over here, you'll be able to see the amount of astigmatism, aberrations, and especially the coma is what we look at, because I've found that, as the coma goes up, that's what the patients really, really hate post-surgery. And so with the pupil of 4.0, you've got that going down to 2.5. It's getting less, down to 2 is even less, and at 1 millimeter pupil, it's even less. So this is something that we would all kind of expect, but it's really nice to be able to see this and to kind of show it to the patients as well. How are we doing on time?
Good.
Okay. So in this patient, the cataract was a small part of the problem. So whether we do the cataract surgery or not, managing the pupil size actually became an issue. And that's what we did. We were able to treat it pharmacologically and help the patient a lot more even before the cataract surgery. Held off on the cataract surgery and were able to keep the patient happy in that way. And I think that would be difficult to make that decision and difficult to explain to the patient because they come in from a referring doctor saying your problem is the cataract. And in this case, it certainly wasn't. And so I was just trying to demonstrate that the technology is really cool to be able to help make these decisions, but then also help educate the patients, because that's a kind of a tricky situation. The patient sent in from a referring doctor, you need cataract surgery. They had some cataract there, but that really was not the problem here. Okay.